Okay, well, it is 12 o'clock, and I want to welcome everybody to our Dissemination and Implementation Town Hall. My name is Laura Parent. I am with the Clinical and Translational Science Collaborative of Northern Ohio, and we would like to welcome you to our town hall event. This is meant to be an interactive town hall where you can bring your D&I projects and questions for open discussion. And really just a chance to engage with our CTSC D&I team. They're here to offer guidance and support on frameworks and how to really effectively manage and measure your quantitative and qualitative implementation outcomes. So we have received your questions prior to the town hall event, and so those will be answered today at some point. If not, please feel free at any point in time to unmute or put your questions in the chat. And our team will be here to, of course, answer those. So I'm going to pass it off to our CTSC site lead for the Cleveland Clinic and our D&I lead, Dr. Anita Meeser-Hebert, excuse me. And so welcome, and I will pass it off to you.
Thank you so much, Laura, and thank you all for being here. We are very excited to have this type of presentation because a lot of times I think that when we talk about dissemination implementation, we give a didactic presentation and people still leave a bit confused about how they can incorporate D&I into their work. And so we're kind of hoping to break down that barrier and just be available to you. We will plan to have some discussion that we may help generate in terms of questions that you may have. But really, at any point, please interrupt us. If you have questions, you can put things into the chat or you can come off mute as well. So everybody should be able to do that. So I want to confirm that you can see my slides. You can see my team here. Okay, so Laura, as she mentioned, I'm the Cleveland Clinic site lead and the dissemination implementation lead for the CTSC. I'm a practicing internist as well at Cleveland Clinic. And I'm just up there is our team, our CTSC D&I team. Mario is our administrator for our center with the Cleveland Clinic and our core as part of the CTSC. Valerie Chepp is our qualitative methodologist, and Stephen is our quantitative methodologist. Belinda also helps us specifically related to quantitative analyses and cost questions, cost effectiveness analyses. So I want to start really with a slide that defines implementation research because we should always start with that. So what is implementation research? It is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice. And the goal of this type of science is to improve the quality and effectiveness of the care that we deliver. And it was called a relatively new field back in 2006, and still to a lot of people, it feels like a relatively new field. But definitely the important part of implementation science is it looks at influences on how providers act and how that affects care delivery, what organizational characteristics may affect care delivery. So definitely requires mixed methods, qualitative and quantitative methods to capture the information that we need to when we use this the science. So I am stopping there, and I'm going to have my some of my colleagues say a few words.
Yes, so we thought we wanted to situate this discussion in a real world application. We wanted to make this tangible, and so we thought it would be helpful to begin with a discussion of a case example. And specifically, we would love to hear an example that you all have encountered in your own work, either in terms of a project maybe you've tried to implement, or a project where you've thought about including an implementation aim, but you weren't sure where to start maybe. And so just take a moment to think about your own work. And if you have an example of how you've tried to implement or even thought about integrating implementation research into one of your own projects, please put it in the chat or feel free to unmute yourself. As we said, we want this to be really interactive and relevant for the work that you do. So if anyone would be willing to share an actual case example, this might be a real nice way to kick off our discussion and start talking about D&I. So please feel brave to do that.
Yeah, so while you're thinking about a project where you thought about adding an implementation aim, let me invite you maybe to engage in a discussion about our latest implementation project. This is something that we've just kicked off, and to give you some context, we had a fantastic opportunity to apply for PCORI funding aimed at expanding access to obesity treatment in primary care settings through an innovative group visit model and a collaborative multi-specialty team approach. So I'm excited to say that we successfully secured the funding, and this is something that we could kick off with as well. So Anita, could you share your insights on the thought process behind our application for this implementation project? It would also be great if you could clarify how a typical implementation project differs from, say, a clinical trial. Yeah, Anita, maybe just some insights as people are thinking about sharing examples that they might have.
Yeah, that's great. And so this, just to help people think about it, I'm going to talk about our obesity shared medical appointment implementation project that we have just started at Cleveland Clinic. And as Stephen mentioned, we have had this amazing opportunity to apply for this funding through a very special program that is sponsored by PCORI, the Health Systems Implementation Initiative, which really focuses on implementation. And so it's not research, it's actually, we have evidence that, and it's often PCORI funded studies that have generated this evidence, and then we take that evidence and put it into practice. And so our whole project is focused on that implementation phase. So one of the things, and this might be a question that many of you in the audience could be asking, is my project ready for implementation? And what does that actually mean for your project to be ready for implementation? So whatever your practice of interest is, it's a medication that works, or it's a practice or a way that you deliver care that works. Has it already shown efficacy? The answer needs to be yes for us to be ready for implementation. This has to be tested. We have to know that it's evidence-based. Has it shown effectiveness within the routine care setting where you want to implement this? And if indeed those answers are yes to those first two, then you are ready to do an implementation study. And so that's kind of where we were with this project. And I'm hopefully just by describing just in a couple of minutes what we did with how we're planning our project will help you to think about whether your project is ready. So we had this opportunity to propose an implementation project to improve obesity treatment within our healthcare system. And so we knew within our healthcare system that we had been implementing shared medical appointments on a small scale to treat obesity, and we knew that they worked. We had evidence of the efficacy. We had evidence of effectiveness even in our patient population. So what we did is we proposed to implement this particular model of care, so that's our practice of interest, our shared medical appointments, across all of our Northeast Ohio primary care practices. So it's 56 practices, and this is where our implementation project started. So we had to come up with proposing mixed methods to understand context. We had to think about implementation strategies and how we would design that. And then in terms of testing, this is not an implementation trial that we're doing, so we're not testing strategies against each other, but we're actually going to look at retrospectively which strategies we decided to use, which bundle of strategies, and whether the uptake was significant for these strategies and what the long-term effectiveness was in terms of weight loss. So that's just an example of the thought process that you have to go through when you're thinking, well, is my project ready for implementation? A lot of people will come and speak to us about projects that maybe are at this stage where it hasn't shown effectiveness yet, but they would like to test effectiveness and implementation at the same time. There is a study design and implementation science called a hybrid trial where you can do that, but that is not a pure implementation project. So just for you to at least get a little bit familiar, I love this. Megan Lane Falls, the first author on this, along with two other leaders in this space nationally, Dr. Vedas and Curran. And I think it's a really great diagram to at least answer that first question. So I think that I could have, if we don't have questions from the group yet, or again, please feel free to put something in the chat if you want to add something to this, or whether you've had an opportunity to think through something like this and think about whether your project's ready for implementation. But I can, meanwhile, Valerie and Stephen and Belinda may want to give their experience.
Yeah, I see we have something in the oh, that was Laura. Feel free to unmute. Yes, unmute your mic and chat.
I do.
Yeah, go ahead.
Oh, sorry,
please.
I do have a question.
Oh, yeah,
And
what is it?
I need to preface it that I'm very naive about implementation science. So I do have an example question. So I'm a speech language pathologist, and I specialize in stuttering, working with children and adults who stutter. So in Ohio, we started a group of speech language pathologists who want to learn more about stuttering, because traditionally, over the years, many studies have found that one of the areas that speech language pathologists feel very uncertain and not confident working with is stuttering. Mm-hmm. So we started a group that provides some continuing education opportunities and other things to increase the confidence of speech language pathologists working with people who stutter. So is something, not in its current form, but is training providers in an area part of implementation science? And excuse my ignorance.
Yes, go ahead, but I will let my colleagues go ahead.
I think that was a great question. So is training an example of a practice of interest, essentially, in this diagram? And I would say yes, if the practice, it has the training already been shown to be effective in increasing confidence among the speech pathologists.
Well, we haven't collected data for that because it was purely just to support colleagues. It wasn't to do a research project. It was kind of on the side. But my laughter was, that's definitely data I want to collect, but I would be shocked if the answer is no, because anything you do extra, I think, has shown to, at least the self-perception of being more confident. I would expect that to be the case.
Mm-hmm.
And from a different standpoint, I would think of the training as an implementation strategy to try to achieve the goal of having more speech language pathologists use whatever the product of the training is, or that, whatever the practice is that you want to promote. So training would be a strategy to then reach an implementation outcome of increased adoption of that practice. So training could be a strategy. There could be another like you could use just improving awareness through some sort of public service or campaign. I mean, there could be different things that you do if your desired outcome is increased adoption, because adoption is a kind of a standard implementation outcome. And so you could use that as a strategy. So if that would be one way to think about it. And Stephen, I guess, is sharing maybe something on implementation strategies or outcomes. Yes.
And I was
Thank
going to
you.
say,
You're muted, Stephen.
Stephen, you're muted. Yeah, just while Stephen's getting unmuted, I just wanted to add in too that from the health economics point of view, you've got this strategy where, your clinicians are getting more comfortable with the program. Health economics just isn't about the dollars and cents. Like maybe you found this program is really helpful, but you want to expand it or you want to get it formalized. So you can do, economic evaluations of the allocation of time from your clinicians to attend this training. Or maybe, additional training would be even more effective. So you can use these evaluations then to look at formalizing the program or expanding the program to make it, standardized, to offering it to more of your clinicians. So that's another thing that, the health economics component can do to help in your implementation and, expansion of your program.
Yeah,
Thank
so
you.
just to come back, thank you. I think you can still see my screen here. To emphasize the point that Anita just mentioned, implementation strategies. So this screen, what I'm trying to show is what are implementation strategies. So these are the things that you do to implement an evidence-based practice. So kind of taking a step back a little bit, it is also possible for you to compare implementation strategies, like you have training versus maybe training plus coaching. So you say, okay, I want to understand or to learn which implementation strategy works better than the other. But also you could have implementation strategies as a bundle. So as a bundle means that you have a number of strategies that you've put together and you are implementing them together. Your interest is not in seeing whether any of the strategies within that bundle works better. No, your idea is, okay, as a bundle, could they work better? So implementation strategies are the things that you do in order to implement an evidence-based practice. So another thing to take note of is that when you have these implementation strategies, usually, as you've mentioned, the target may be is likely going to be the provider, right? The target is going to be the provider, not necessarily the patient. So that's important to kind of mention when it comes to implementation strategies. And to give you a quick example, for the project that Anita just mentioned, we have a number of implementation strategies that are being used together. So it's not like any of these, because we have training of PCPs, we have distribution of education materials. These implementation strategies are not being used in isolation, and we are not comparing one against the other. They are being used together as part of this project. So I just wanted to kind of emphasize what implementation strategies are, but also give these examples. But my colleagues can continue.
Thank you so much. And congratulations on your funding too.
Thank you. Thank you.
I am seeing a few things in the chat that I just want to mention. Brian, you are letting us know about the STAR table. Thank you. We appreciate it. And you said training is definitely a strategy. In many instances, training is necessary, but not sufficient. Yes, you're absolutely right. And just the bundle that Stephen just referred to, absolutely agree with you. If you have thoughts about facilitation, Brian, I'm happy to hear what your experience may have been with that.
Oh yeah, well, absolutely. Thanks so much, and nice to be here with everyone. Facilitation is something my colleagues and I have been testing since about 2014. We've developed the implementation and sustainment facilitation strategy. It essentially is using motivational interviewing instead of with patients. It's using motivational interviewing with staff to try to help motivate them for greater implementation, also, problem solving. But we do it virtually 30 to 60 minutes a month, and showed that that was effective above and beyond a very comprehensive training plus coaching in the intervention and feedback. So facilitation worked above and beyond all that. And we just finished up a trial where a follow-up study where we gave everybody the training and the feedback and the coaching plus facilitation. And then the only difference we did was we added modest size incentives for implementation. That worked above and beyond everything else like that. So we've kind of bundled those into what we sort of are branding called motivational facilitation and incentivization, where we are trying to use motivational facilitation and motivational incentivization together to try to help draw on people's intrinsic motivations, extrinsic motivations, to create habit formation so that then they continue implementing during the sustainment phase. And
that is so interesting. Thank you. The incentive goes to the providers.
Yeah.
Is that right? Oh,
Yep.
okay. Not to the practices. Okay.
Doesn't work. Yeah. The trickle down incentives don't work, but especially to frontline staff, the ones who are expected to do it. I mean, we were trying to implement motivational interviewing. So it's kind of funny. We were using motivational interviewing to help implement motivational interviewing as a brief intervention for substance use disorders, and a $10 gift card for every time that they implemented the brief intervention, and then $10 for every time that when they delivered it, they met the fidelity benchmark, like the high quality benchmark. So we were incentivizing how much and how well. And so for $20 on the line, we had over 100% difference in implementation between that and the other very intensive control condition.
Love that. That's fascinating. And your IRB had no issues with it, I'm assuming.
No, because I mean, we had used that before. Because here's the thing, like I always try to say, is that we give people facilitation and it costs a lot of money. Like facilitators cost like $100 an hour. You gotta train them, you gotta supervise them, and they don't guarantee you any results. With the incentives, you only pay them when you get the behavior that you want. So they're super cost effective, and you don't have to do it forever. You just need to do it to kind of motivate them to try, because oftentimes just getting them to try is hard. Get them to do it long enough for motivation. And in a previous trial, one that we published in 2012, we showed that a 5% increase in cost for incentives led to a 116% improvement in implementation and a 325% improvement in client outcomes for a 5% increase in cost.
That's awesome. And I guess you'll be studying now how long this is sustained with your current study that once you take a degree.
Yeah, I mean, actually, we're just continuing to kind of test incentivization. Actually, now as a dissemination strategy. So because we tried using facilitation as a dissemination strategy, like how do you get it out at a national scale? And the problem is again, the facilitators cost a lot of money to pay. They were trying to call these organizations, and they couldn't hardly get anybody on the phone. We could reach them by email, and so we think that by reaching them by email and dangling a small modest size incentive, will do way better than the facilitation, because the facilitation struck out. We just couldn't, get somebody to listen to our introduction script and informed consent. So hopefully this incentives might work there too as a dissemination strategy. So we're kind of going the other direction instead of sustaining. Do it at a national scale.
Yeah. Well, thank you so much for sharing that experience. That's great. I am looking at other things in the chat. What steps can be undertaken between the identification of the practice of interest and the measurement of practice of interest efficacy? How are those steps managed from the implementation research perspective? So the practice of interest efficacy needs to be established first before you're thinking about implementation. And please tell me if I'm misunderstanding that question. Theory. I don't know if you put the question in. I mean, I would say that would be my answer, is that efficacy and effectiveness need to be established first. So that answers, I think, the first question.
What's efficacy?
Dave.
In the context of a socially complex intervention and setting?
You know, the way that I always interpret that is you try to implement a practice in a very controlled environment, and you don't call it research. It's not clinical research, but it's the efficacy that you might see in a small group of the practice, one practice site maybe, and then not effectiveness yet, where you're looking at maybe a more diverse population where you're trying to implement it. That's how I interpret it, but you, as an expert, may say something different.
Well, I don't think there is any such thing as efficacy, frankly. The only question is, do you have enough evidence of effectiveness? Because I think fundamentally, implementation is a function of the interaction between the intervention, whatever that intervention is, whether it's motivational interviewing or motivational dollars or pay for performance or whatever, and the context. And contexts are just remarkably different. So all you have to do, I think, is show it worked somewhere once.
Well, point well taken. That is very true. And I think this obviously is trying to follow more of like a drug development trial, and to get more people to kind of think that way about implementation. But no, you're right. I mean, you've seen one place and you've seen one place, which is what everybody says about implementation, right? It works in one setting, and who knows if it will work in the other. So I agree with you. Thank you.
I think it is important to differentiate between what you say and do for the purposes of getting funding and what you say and do for the purposes of actually accomplish something in the real world, because the two are not the same. Sometimes they overlap, occasionally. Usually they're tangents.
Okay.
But then I'm old and, I've done this a long time. And I have the scars to prove it.
Okay, I am looking at, there are lots of questions in the chat. I want to, Cytherea is just fine. Yeah, true, you've already identified the parts of interest, but in between you need to measure efficacy, which may perhaps imply something is being done. Okay. Yes. There is probably a smaller scale implementation project going on, and maybe I think maybe that's how, I think after we had the discussion with Dave, I agree. I mean, it is difficult to say that proves efficacy on the smaller scale when the context could be very different. So I think that we did have a request to hear more specifically about a mixed method study, an example. And I will get to that. I want to actually address, unless somebody else has a comment that they want to address first, I wanted to address, somebody had asked as a pre-question, and I think I'm no longer sharing my screen, right?
You are.
Oh, I am.
Mm-hmm.
Okay, it was very strange because when Stephen was sharing, it said I was sharing too, and so I didn't really think that was true. So I wasn't sure what that meant. Well, somebody had asked about non-research faculty personnel, like research personnel that aren't faculty researchers, and how best to engage that group in implementation studies. So that was one question I wanted to ask, actually. Mario is on the call. Mario Scarsapino is our administrator and works with our center at the clinic and also through the CTSC. And from the administrator's point of view, because D&I involves so many different types of personnel that would be involved in an implementation project, I wanted to have Mario give some insights on his journey in becoming very well-versed in D&I as not a non-research faculty personnel.
Great, thanks, Dr. Mr. Hebert. And I really do appreciate the question. It provides me certainly an opportunity to reflect on my personal journey. And the last part of the question, I know it's not up on the screen, but I'm not seeing it now, but it talks about being allies in this growing field. So how can we as faculty, staff, or administrators be allies in this growing field? I think really just that statement itself, for me, reinforces the positive impact that we can have in the D&I work and what our role can be about that. So about 6 years ago, when I started working in the space, I had no direct experience whatsoever in D&I or implementation science. And now being part of our center certainly provided me a platform for learning, but I really leveraged traditional strategies for learning, like, reading publications to familiarize myself with the terminology, the frameworks, the concepts, listening to the colleagues and experts in the field, and really attending a lot of educational sessions, just like our town hall today. And so the other unique way I probably approach that is starting to familiarize ourselves what we have to do administratively with regards to funding opportunities, what the requirements might be for like a D&I application, different ways to just gain information, really listening and taking a step back and really absorbing. And like any new learning, it certainly has taken me time. But what I've always kept in open mind, understand that we have to pursue both traditional and non-traditional resources. Understanding that our learnings are going to continue to evolve with each new experience and each new interaction. And when I really realized, again, 6 years ago, not knowing anything to where I am today, we oftentimes don't give ourselves the credit. So maybe we're uncomfortable speaking about a topic. We don't feel, because we're not researchers. Again, we're admin or we're non-faculty staff trying to support operations or researchers. So the first time I attended a national D&I conference, the terminology and the lens through which the work was conducted was so new to me, certainly different than clinical research. But then I recently attended the conference in December, so a few years later. And while it was not my intention to measure what I had learned since the first time I attended, I was so personally rewarded just by being able to network more effectively, having a deeper level of engagement in the sessions. And again, I attribute this to the fact that learnings and experiences are garnered over time. So I've talked about sort of some of those traditional things, right? How I've learned, but really what our role is. And then when we start to really become acclimated and aware of these terms and these concepts, and we continue to evolve through our learnings, we need to also recognize whatever our environment might be, academic setting, hospital setting, but we need to understand who the stakeholders are that are going to be involved in this work. Otherwise, know who's going to need to be involved to implement whatever we're talking about into practice. So we're talking about research stakeholders, clinical operational stakeholders. And then we need to really take a step back and recognize and understand our role in sort of bridging the work between the evaluation work of D&I, which you can call that the research efforts, and the operations and the clinical component. That's where our work as admins and non-faculty staff, for me personally, has really provided some visibility to the work that we do. And then having a role in translating the research frameworks that are used, such as what we're highlighting when we're talking about our RE-AIM framework, our CFIR framework. And then one thing that has really been an effective strategy, I think anyone on this call, when you're working with anyone, so whether you're working with a department head or you're working with a team or an entire organization or a department, is finding ways to connect and align the priorities of your work with their work, understanding our roles in the process, and then really forging those relationships. That's how you build that value. It's about it, at the end of the day, we got to realize it's like, it can't just be about how we're going to benefit from the work. How are others going to benefit? How are we really, at the end of the day, serving the same purpose to move forward our efforts? It's finding that alignment, to me, that has really allowed my work in this space as part of the team to really resonate with others and for me to find meaning in that work. So I would just say in closing that these are just examples of how we as admins or non-faculty staff can contribute to the growth of D&I work and really become partners in these efforts. But thank you. I really think that was just a great question. So appreciate the time.
Thank you so much, Mario. I mean, there's so much complexity in the work that, especially this current project that I mentioned already that we're doing now. And and if we didn't have Mario as part of our evaluation team, that was this bridge, with the whole operations part of our project. Just the value of having non-faculty, what they're referred to as non-faculty research staff. In this world, it's extremely important because we can't be researchers just sitting here trying to implement things and not really understanding what's going on in the operational world. So I appreciate your reflections, Mario.
And if I could just add one more thing, Anita, I work in a lot of different areas, not just in dissemination and implementation. And I work in an area where people are often confused about the work that I do. But I need, people to partner with me in order to get my work done. What I find is a lot of people just get confused and turned off when we use a lot of terminology, which might be, something that we use every day and is normal for us to talk with other researchers using those terms. But to other people, it can be a turn off straight away. Where when you sit down and actually, explain to them in fairly simple terms and get them to realize that we're actually talking about things that they probably are of interest to them, they just might know them by another name, or explaining to them exactly what you do, but in, much simpler terms, I tend to get a lot of buy-in much easier from people who aren't necessarily in the research world. So, my takeaway is always don't sort of deter people with, the terminology and the big words. You get much better buy-in if you sort of break it down and speak about things that are of interest to both of you.
Thank you, Belinda. No, that's very important. And I think D&I is often accused of having too much terminology that seems foreign to others who may actually be doing implementation work, but aren't calling it that. And so that's a reason to have a forum like this, just to have people just realize that whenever you're trying to translate evidence into practice in some way, you are in the D&I space, and maybe as a practitioner, and still could benefit from framing your work, maybe using some D&I methods. So I want to bring up this question. We had more than one question, and we get asked this all the time about IRB issues. And how do you differentiate D&I from quality improvement? And Dave, I think you put a citation in the chat, I think, related to that. And that's kind of like this never-ending question that people ask about how is D&I different. And I always, a simplified way is, it's longer term. Sometimes it's not these quick improvement cycles. And I think that there's always going to be a debate. But I wanted to specifically talk about that in the context of IRB, because there seems to be this differentiation in the IRB. Well, this is QI, this is research. And here we are in the implementation world coming in somewhere in the middle. And so I actually was hoping that Stephen and June, who is another wonderful example of a person who is a non-faculty research staff, our research nurse, who has learned to navigate this with all the work that she does communicating with the IRB. So June and Stephen, I will turn it over to you.
Sure. Thank you, Dr. Meeser-Hebert. And boy, is that a great question. And I'm just realizing that Mario has 6 years and I'm just coming into 1. So there is definitely a learning curve here. But from a research nurse coordinator perspective and experience, it's definitely a learning curve in submitting an application for an implementation project to the IRB. It does take a lot of collaboration between all the team, the qualitative, quantitative team that we have. But being specific and differentiating an implementation project, being very clear in expressing that this project is part of routine clinical care, and that from a traditional clinical trial is definitely the goal here. So I'll just give you an example of an experience that I had. So we were recruiting for our project for an advisory panel. And the IRB, when we submitted this concept to them, they considered recruitment of employees and patient volunteers as research. So in responding and resubmitting back to the IRB, our team needed to be clear of how this process would work and how it would flow. So for our employees, providers, we would invite them via email and we would get permission from the site director to approach them. And we would also provide these employees with an information sheet. So the information sheet detailed the purpose of the advisory panel, and then the employee would respond to the email if they were interested in participating. While the patient volunteers was definitely, it was much more of a process. IRB approval was obtained for us to reach out to the patients via MyChart messaging through our electronic medical record. And we would ask them if they would like to participate in this advisory panel. And so the patient would indicate through MyChart whether they were interested or not. It was simply a checkbox. And if they were interested, I would then, as the research nurse coordinator, contact that patient directly and then go over that information sheet, and they would verbally consent their willingness to participate. Now, what is this advisory panel purpose? So it's to gain insight from our providers who participate in SMAs that treat for the treatment for obesity. And then from the patient's perspective, we're seeking their insight and feedback related to their prior participation in a shared medical appointment. So the key word here is the verbiage that you present and provide to your IRB to get it across that it is part of routine clinical care that will differentiate between implementation and a traditional clinical trial. But Stephen, I'm sure you have more to add here.
Yes, but maybe in the interest of time, I've seen that David has unmuted, so perhaps he wants to, he has a comment, so I would let him maybe comment.
Oh, I just put some comments in the chat. I unmuted by accident. I mean, I'm always willing to talk, but other people should have something to say.
Thank you, Dave. No, I think in this situation, thank you so much, June, for describing it. I think that the key was also that Valerie, as part of her qualitative data collection, maybe you can explain how you were thinking about the advisory board versus in other situations where we may not be using an advisory board in a similar way.
Right. So for us, we actually included the advisory panels as part of our evaluation plan. So we're using the advisory panels in maybe a traditional way where we're getting input and insight from these key stakeholders. But also because, and this might tie into some of the questions about methods that have been asked and mixed methods, because qualitative research can be quite time consuming and laborious, which is sometimes at odds with implementation evaluation. We don't have years and years and years to collect qualitative data. So when we designed our qualitative evaluation for the SMA project, we tried to think about being very pragmatic and how can we streamline things that we are already doing in routine ways. How can we also leverage those routine things as opportunities to collect some qualitative data? So for the advisory panels, we're doing those panels as a way to get information about the project, but we're also viewing them as an opportunity to take field notes as observations. So during advisory panels, we take both meeting minutes of the content, and then we have a qualitative researcher who is observing the panel and taking field notes. And so you're kind of getting, a 2-for-1 there. We're getting also qualitative data during that. And the IRB asked us in that context the IRB is seen perhaps because of that evaluation component as it counting as research, right, Anita? Because we had to get consent then. You're on mute, but yeah, we had to get consent then.
Sorry.
Which maybe we wouldn't have otherwise, but because we framed it as
Right.
part of our evaluation plan, then it started to sort of creep into, the research, rather than just kind of routine things.
No, and I think that is. Oh, I'm sorry, Stephen. Go ahead.
No,
Didn't
I
mean to
just
cut you off.
wanted to say that trying to answer the question directly, the difference between implementation science and quality improvement, the way I look at it is that for implementation science, you have a practice that you want to introduce in a new setting. It has been proven to work elsewhere. Now you want to introduce it in your setting. The methods that you're going to use to study how that's happening, that would be implementation science. But in terms of quality improvement, the way I look at it is that you already have these processes in place at, it could be at your health facility or within your system. You already have these processes. Now you want to systematically understand or improve these processes that are already existing, then that will be quality improvement. That's how I look at the two. But Anita, you can chime in, yeah, to round up the discussion.
No, I think that the debate cannot be solved in this session, because I think that there are always different ways where there are nuances. But I appreciate what you said, Stephen. I think we do our best. I think the most important part is to explain exactly what you're trying to do when you're especially related to the IRB. And Stephen, as part of our proposal, I recall, we had a whole paragraph at the beginning of our IRB proposal kind of explaining that what we were doing is part of routine clinical care, but there were clearly research components to what we were doing in terms of qualitative data collection that would not be part of routine clinical care. And so we had to clarify those, and we acknowledged that those required all of the research protections that that we're used to abiding by. So, okay, I don't know if
we have a question in the chat that was asked a little earlier. The question was, what's the research question behind the SMAs for treating obesity? So maybe you might want to.
Implementation project, Dave. I think I saw you. It's really just, there's no, so it's really just implementing. We don't have hypotheses and research questions because it's really at that last phase where it's not a trial. We are not testing anything. We are taking a practice that we know works, and we are implementing it and scaling it up to the all of the practices in Northeast Ohio.
Right. So the scientific question has to be a question about implementation, right?
Right. We do have effectiveness outcomes on this. I mean, we are going to see if people lose weight as related to this program, but it's not, the goal is really the implementation outcomes. I mean, how far is our reach? How far, what is our adoption? What's the acceptability and feasibility of this for patients and providers? So it's essentially really the implementation outcomes are the focus, but of course we are measuring the effectiveness long-term for our patient population.
Sure, but implementation outcomes, assessing implementation outcomes is a scientific question, right?
Yeah. Agree. It is. But we're not testing anything. So that is, yeah.
Oh, sure you are. You may not admit it, but sure you are.
Yeah. So I wanted to make sure that we also.
There's a question earlier. Oh, were you getting to it, Anita? Valerie asked a question earlier about an example of a mixed method study to understand context. This was earlier in the chat.
Oh, okay. Go ahead.
And I could share. So again, returning to our SMA project, I can share. Hello. Can you all see my?
Yes.
Okay. So this is an example of how we are using mixed methods to capture just some implementation science outcomes or insights. We have others, but this is an example that we can talk about. So we are doing observations. I just talked about observations we're doing of advisory panels, but we also are conducting observations of practice sites during this pre-implementation phase that we're in right now. And we're doing that in an effort to just start to understand context, right? What's the usual workflow of care delivery at practice settings? What are some interactions that we can document, behaviors? And we're doing this in an effort to start to see if we can identify any possible barriers and facilitators that might come into play when we get to active implementation, when we're actively implementing the SMA. So this is one way we're trying to capture some ideas about the contexts in which we are going to be implementing this, to see if there's any strategies we can identify up front that would help us either overcome barriers or maybe encourage some facilitators to implementation. We're also going to be drawing upon semi-structured interviews, another qualitative technique. We're interviewing providers now during pre-implementation, but we're also going to be interviewing patients during active implementation at these 3 different time frames to understand how they perceive outcomes around acceptability. How acceptable, how satisfied are they with the SMA program? And then we're going to be also administering surveys to providers during active implementation, again, at different time points, to assess feasibility and acceptability among providers. So that's an example of how we're pulling together some different methods, both qualitative and quantitative, to paint a picture of the context in which we're implementing our study.
Thank you, Valerie. And Stephen, I mean, you have a whole list of other quantitative outcomes that you're looking at, both implementation outcomes and effectiveness and healthcare utilization outcomes. I mean, I think that is, those are the surveys and the interviews, and then we also have clinical outcomes that we will be looking at, maybe just really just observing retrospectively after the implementation is completed. So yeah, that was, and I don't know whether I know we have 8 minutes left, and we definitely spent a lot of time, and Stephen did, with defining our data, our data definitions of implementation outcomes to be captured through the electronic medical record was a task that was took some time, but I think we got there, and that's also another huge piece if you are trying to do implementation work in a healthcare system, to make sure that you are able to capture the outcomes that you want, and that your IT team is aware of what needs to be captured when you're looking at different levels of practice level, provider level, healthcare system level of anything that being implemented. So I think, because you will go to your analyst and say, I need to know the % adoption, and you need to make sure you clearly identify what you're asking. So I think that's something also just to be aware of, and we are available to answer questions about that as well. I'm looking at, there was something I did want to show about, there was a question about how best to leverage the collaborative and I think clinical trials network for site recruitment. I wanted to actually mention that we have in our CTSC, Jerry Trubo, who's available for consultations for recruitment support. And I don't know if those on the call know that, but this is the website, and you can put in a Spark request if you do have questions about recruitment and assistance with that. If you want to do multi-site studies, just related to that too, there was a question about resources for D&I, and we do have a website. RCTSC has a website with a bunch of different resources. There is a series, a webinar series from the National Cancer Institute that is still available. It's free, and if you went to this website, our D&I website for the CTSC, you can scroll down under resources. And for anybody who's kind of brand new to the field, it's actually worth your time to watch some of those webinars. It was part of the Training Institute for Dissemination, Implementation, Research in Health, which I know that Dave was involved with and I participated in when it was available. It's no longer available, but those webinars are available. And so they're really good. So that would be a great resource. So for you to go to this site if you're interested. I just wanted to make sure I said that, but please go ahead. Others, there are other thoughts. I see a question. Do you have suggestions for phasing implementation strategies and research approaches when bringing a behavioral intervention to a large health system? When and how do you study each phase of implementing a new intervention? Are you testing the research approach? I guess I'm wondering if you're asking about potentially hybrid trials that could be done where you are testing an approach and also capturing some implementation outcomes that may then inform future strategies. Because you could do it at that stage when you're testing effectiveness. But if effectiveness has already been proven and you're just trying to scale up like we're doing in our project, I think something similar to what we're doing is we have some operational implementation strategies in place, and Stephen showed you on the slide, but we are collecting some research data about that during the implementation itself, both qualitative, observations, interviews, and then kind of collecting adoption, site specific, doing audit and feedback. And so I think that's the question you're asking, unless you would like to clarify.
Yeah, thanks. I was just sort of thinking about, you've got a large health system that has not had an intervention before. Let's say it's like a teaching kitchen intervention, right?
Mm-hmm.
Eventually you'd like to bring it, throughout all primary care, but you need to start somewhere. And, there are interviews and there are surveys and different kinds of strategies for measurement along the way. But sort of where would you start initially, let's say in a healthcare system that has not had a particular intervention before?
So testing something that's proven, but in a new setting. So I think that actually that potentially you could do a hybrid trial and actually test the effectiveness of the intervention. So those who get the opportunity to participate in that test kitchen versus those who don't, and then also then capture implementation outcomes where you have a primary implementation outcome of adoption or feasibility, in addition to the effectiveness outcome, if it's a brand new intervention that hasn't been tested in that setting. That would be my thoughts. Others on the call may have other thoughts on that.
Yeah, in terms of like health economics, if you're looking for resources to, set it up in a new area or a new setting or for a new population, you can even do, we call them preemptive health economic analyses. So using any data that's already published or data from implementation in other settings, you can come up with thresholds of, how effective would this intervention have to be, or, what kind of adherence would you have to get in order for this to be considered like a successful intervention. And, usually if it's in a reasonable value, a reasonable range, then you can use that as evidence to go and, say you want to expand it and, try it in this new setting, and then use that same model in your evaluation piece. So there's different ways you can go about it too if you need additional evidence before trying for the implementation.
Yeah, sounds great. Thank you so much. I know that we're just about at the end, but for some of the resources that we have or have created, as Anita mentioned, we have created materials that can be used like for pulling data from the EMR when it comes to the quantitative outcomes. So that's very important, and it's something that we have used in training people within the enterprise, just to make sure that everyone is on the same page when it comes to pulling data or what needs to be done. So there's a lot that has to be done before that. Yeah.
Oh, you're muted, Anita.
Yes.
Sorry, I really appreciated Marie's comment about thinking about site readiness during pre-implementation, and it's definitely an approach to try to implement at sites that are more ready for a new program. Interestingly, we in our program decided not to do that, and we just decided to go to all of the sites, and that's just the way our health system is set up, is that all of primary care is kind of under more of a centralized governance structure. So it seemed okay for us to be able to do that because we figured that resources would be similar in all of the settings, although I'm sure that there will be variation. And so we decided not to take that approach, but I do think that's a really important point. Dave, your final comment: find out what your leadership values, what they will want to improve, and plan implementation project that addresses those values. This is how we implement SMAs for diabetes at the VA almost 20 years ago. Yeah, I mean, that's so crucial. And so in terms of our PCORI work, I mean, we actually have to demonstrate it with this program that our health system is completely on board with anything that we're proposing. So I mean, I think that that's a crucial point. Thank you. We are at 1:01. Thank you so much, everybody, for joining today. And please contact us if you have questions. And we're really trying to promote this work and have more people involved and realize that maybe what they're already doing does count as D&I, and maybe you want to get more training, get more involved. And it's so important. We want to bring all of our research findings to our patients who can use them. So anytime you want to talk to us about, we have consults available, that same Spark system. Love to speak with you more.
Thank you,
Thank you, everybody.
Thanks.
Have a good afternoon.
Yeah, thank you.